To shock or not? That is the question. Hello everyone, welcome to the Rhythm Files episode 3. Let us have a look at this case of wide complex tachycardia and differentiate between an SVT and a VT. So, wide complex tachycardia in itself is a high stakes situation. So, instead of looking at the ECG step by step, we pick out certain important leads that will lead us to the diagnosis. Now, if you look carefully here, you'll see that there is an upward positive deflection in the leads V1, V2, and V3. This is basically the R wave and can be clearly seen in the lower picture. Secondly, the RS interval is around 2 small squares, which comes out to be about 80 milliseconds. And on even closer observation, you'll notice that there is no obvious AV dissociation here. Now, these points are specifically important because they constitute a widely discussed criteria to differentiate between an SVT and a VT, and that is the Brugada criteria. So, this criteria gives us a practical inclination towards either diagnosis. It is not confirmatory as such. So, if you remember the previous ECG, you'll notice that the answer to the first question is a no. The second one, that is the RS interval, was around 80 milliseconds in this case. So, the second answer is no. There are no signs of AV dissociation. And lastly, the QRS morphology is not consistent with VT. So, this patient is likely to have SVT with aberrancy. However, in the real life settings, it is difficult to look at all the leads at once and calculate the RS interval and look at V1, V2, and V6. So, there is another criteria that provides a shortcut to diagnose a wide complex tachycardia as a VT or an SVT. And this one uses only one lead, that is the AVR lead. Now, compare the AVR of R case with the AVR of a VT. And we'll discuss the simplified criteria known as the Verike criteria. So in this, we look for an initial prominent R or Q wave in AVR. Next, we look for an initial R or Q duration, if it is more than one small square or not. Thirdly, we look for the notching on the descending limb in the AVR, which is also known as Josephson's notch. And lastly, we look for the VI by VT ratio, that is the amplitude in the initial 40 milliseconds to the amplitude in the last 40 milliseconds in AVR. Now you must know that none of these criteria provide a confirmatory diagnosis for a VT or an SVT. So history and physical examination are a must in any case. So this flowchart from Harrison's combines components of both the criteria, and even here they have mentioned that VT is still possible despite getting an answer no for each question. So this is a practical summary infograph. Always remember that when in doubt, treat the patient as a VT and always consider clinical context of the patient. Thank you. Please like and follow.